Char had once said, the future is not a result of choices among alternative paths offered by the present, but a place that is created. Created first in the mind and will, created next in activity. The future is not some place we are going to, but one we are creating. Let's pause for a minute and think, what will healthcare be like 10 years from now? Will we need invasive monitoring? How much of healthcare will be in hospitals, how much in clinics, and how much will be at home? Will we need to see doctors as much as we do today? And if we need to see them, will we see them face to face, or it will be using technology? Will each of us carry on our smartphones our personal health records and perhaps even our genome with us as we walk in to see our doctor? Will we actually be looking at personalized healthcare? So there are many of these exciting areas that hopefully we'll be able to touch upon, and of course we have a limitation of about 20 minutes because we want to leave about 5-7 minutes for a question and answer. Throughout history, people with new ideas who think differently and try to change things have been called troublemakers, said Richelle Mead. We have 3 very big troublemakers here today. Because if we just look at their profiles, they've been up to trouble for most of their careers. So let me start with Ewan Thompson. He's a physicist. He trained in London, did his PhD, started research, teaching, then went into consulting, and then he felt that he could contribute to business as well. And boy, did he contribute. He took his company, Accuray, from a turnover of 10 million to 400 million in 10 years. So that's Ewan Thompson. So let's put our hands together for Ewan Thompson. Next to Ewan is an amazing neurosurgeon, John Adler. John studied in Boston. He did his graduation at Harvard College, then went to Harvard Medical School, then did his training at Mass General, then went to Karolinska, and decided that he wanted to radically transform neurosurgery. And how did he do that? By not inventing a new surgical technique, but by inventing the CyberKnife. John has been the president of the CyberKnife Institute, and curious that he is by nature, he's now started a company called Curious that doesn't have the O in it. It's Curious.com, and what Curious.com is going to do is to actually give all the established journals in the world like NEJM and Lancet a run for their money, because he's got an innovative way of how the peer review process should be handled, what should be the turnaround times, and he's basically going to address all the frustrations that all doctors have when they go in and send a paper in a high impact journal to be published. So that's John Adler, so let's put our hands together for John. And next to me is Dr. Rajiv Doshi. He did his bachelor's in chemical engineering, and then decided that he must do a master's in biomedical engineering, and then quickly realized that his education wasn't going to be complete till he did a medical degree. So he went on and did his MD, and he's done that all at Stanford. Interestingly, all these 3 troublemakers actually live in California as we speak. Rajiv is the ED of the Stanford India Biodesign. It's a unique partnership. It's brought the Stanford University, the All India Institute of Medical Sciences, and IIT Delhi together on one platform. He's been listed by Forbes India as one of the top Indian scientists, and he actually mentioned in the book Jugaad, which is the Indian way of innovating. So that's Rajiv Doshi for us.
Raj.
So as we start the panel discussion, let's remember what Thomas Edison had once said. There's a way to do it better, find it. So gentlemen, the first question to each of you, and you have 3 minutes to answer that. What, in your opinion, is the where, what, and how for the future of healthcare? Ewan.
Well, I think the easiest one to answer is the where, and I think people have been addressing that all morning. I think where needs to be outside of the doctor's office. I think that's pretty clear. I think the idea...
Ewan, I'm just going to interrupt you. Can you hear Ewan? No? I think if you just put your mic a bit up and be a bit louder.
How is that?
Better.
It's very loud. Okay, now it's too loud. Hang on. We should do the where, what, and how of microphones. Okay.
No, we lost you again.
Can you hear me now?
Yeah.
Good. All right. So as I was saying, I think the where part of that has been answered already this morning several times. I think where needs to be outside of the doctor's office. I think that's pretty clear. The idea of, I feel sick, I'm going to go see a doctor. Those two things don't necessarily have to be connected, and in fact, maybe using different technologies, you can detect certain symptoms and signs before you even get sick. But I think the how is, to my mind, I work now with a whole range of sort of digital health, analytics, big data companies, and I see everything through those sort of lenses. And I think that the how we take things out of the doctor's office is really hinging on the types of technology we can put into people's hands. It's not just about connectivity and remote consultations. It's also about the intelligence that we can put into devices as we distribute healthcare. So for an example, we have 2 or 3 that I could use inside our portfolio at Khosla Ventures, but I'll just use the AliveCore system as an example. This is an ECG device connected to a mobile phone. But it actually is also an intelligent device. We have algorithms that will interpret the ECGs. And for example, and they're good algorithms. For example, we did a test of our atrial fibrillation algorithm using about 1,000 ECGs produced by this device, and had them looked at by 2 cardiologists and run through the algorithm process as well. And the cardiologists were 94% and 95% correct, and the algorithm was 97% correct. So using automation doesn't have to result in a loss of quality, and I think that's a really important factor, because it means we could confidently then deploy a device like this into the hands of non-physicians, let's say, whether it's a nurse or a local healthcare worker, and they can use this on a patient, and they could be, in this example, screening for atrial fibrillation, and then carrying out a remote consultation with an expert, with a cardiologist, without the patient ever having need to have been into the cardiologist's office. So I think that, I know I'm biased because I live in that world now, but I think the idea of intelligent, distributed devices inside healthcare is really going to be the how of all of this.
Thank you, Ian. John, what, how, where?
Is it what, how, where, or where, what, how?
Whichever way.
Well, from my perspective is, when it comes to where, what, how, I don't really know. And I think that no one knows. And that's kind of the beauty of the future. And if you look back, though, you can, I think, understand through the history, through 2,000 years, if not more, of medicine, that the future will always look a little like the past, but it'll also be different. And I mean that somewhat glibly, but I mean it very real, because in the world, if you look back over 2,000 years, the history of medicine has been defined by innovation and the ever-progressive march of science. And so however they affect medicine in the future, it'll be through the where, what, and how of those themes of innovation. And so, innovation is kind of this mysterious thing, and people think that Silicon Valley has some unique hold on innovation. But it does not. And the truth is that innovation, creativity, imagination is just part of the human spirit. And in fact, no one has manifested it more dynamically in Silicon Valley or perhaps the world than Indians in general. So I do think that India has an important role to play in this innovative future of medicine. And kind of what this world might look like? Well, I think increasingly it's going to look like the empowerment of individuals. Now, you wouldn't touch on the fact that healthcare may not be in the doctor's office. Well, I think it is going to be increasingly individuals caring for themselves to some extent. And that sounds preposterous to a lot of people. Medicine is so complex, and you got to go to school for all these years. Well, the truth of the matter is that there have been patients who've been instrumental in my career who have taught me as much about their disease as I've ever learned from anywhere else. And I'm quite confident that if anyone had a disease, like, for example, I had a brain tumor, I think I know more about taking care of a brain tumor than anyone else. So I'd like someone to care for me with the same knowledge that I have. Who better than to have that patient have that sort of knowledge? Because in the end, medicine is about care. It's about care. Now, you can have a process, you can have a system, and I think India is getting ever better at developing processes to to take care of the masses of people. But yet, no one will care for you or your family as much as you will. So by empowering you, by empowering the individual, be it through distributed devices, be it through better information systems, be it through Curious, who I hope to talk more about, I think we will have a healthcare revolution. And India, where you're starting with a clean slate, I think is a great opportunity to explore some of these opportunities. So experiment and innovate, that's how will be the how, the when, and the where.
Thank you, John and Rajiv. Where, what, and how for the future of healthcare?
Where, when, how.
Yeah, it's funny that we've all kind of headed in the same direction. I think as we think about more about chronic disease management and while still thinking also about infectious disease, I think we must acknowledge that for chronic diseases, the patient is the one who's actually treating their condition. It's not, the physician may be an advisor or supporter, but for ongoing care, it's really the patient who's actually in charge. So that speaks to understanding that, awareness about a disease state. It speaks to diagnosis, so actually having the motivation as a patient to go get diagnosed. And then finally, the ongoing treatment, whether it's taking a pill or checking your blood glucose levels, for example, this ongoing compliance has to be managed by the patient. So all this happens in the home. So I think products and services that cater to the patient in the home setting, I think, are part of the future. As far as the what, I think innovation is really critical, especially in a place like India. We need to acknowledge, and this is the basis of our program, Stanford India Biodesign, which is a collaboration between Stanford and the Indian government. We must acknowledge that the clinical needs in some ways may be similar in places like India, in the US, what the solutions look like and how they're delivered may be fundamentally different. So creating locally relevant solutions for those needs is, I think, the order of the day, and I think that's part of the future as far as what. As I think about our program, just to give you one example, our fellowship involves having our fellows spend 2 or 3 months in the field actually observing clinical problems across India, north, south, east, west, and rural settings and urban settings as well. So one of the needs was identified was that there's a lot of road traffic accidents, a lot of broken legs. So a group of fellows designed an ultra-low-cost leg immobilization device, basically a splint, which was made out of cardboard, which provided kind of the, from the time of the injury to the time of definitive care, provided an intermediate solution. So that product was one size fits all, ultra-low cost. It's been licensed to Hindustan Latex, and for me, it just provided a good example of how a clinical need in some ways may be similar, but the solution could be uniquely Indian. So that's my what. It's all about innovation. And then how do we do it? I get back to my educational roots and think about training as a means of promoting innovation in India. As I think about Stanford, I recognize that there must be something in the water there. There's lots of entrepreneurial spirit, new companies coming out, whether it's Hewlett-Packard being formed, a few miles away from Stanford, to Google and Yahoo also starting actually within campus by students. I think once you're able to see one or two precedents, one or two examples of success, then others want to repeat it. People who see themselves as entrepreneurs, they have something to try to replicate, and we're starting to see the first inklings of that in the Indian context through our program. We're seeing some early licenses, some early products being commercialized, and I think that's starting a whole new wave of new products that are relevant for India. So for me, the how is all about innovation training.
Thank you, Rajiv. In the next 10 years, what are the big changes that you're going to visualize if you were going to enumerate them?
I think to me, and again, I live in a particular world of...
There's something about you and the microphone today.
We'll try that.
It's the ECG. Okay, that's a tachycardia there.
Okay. Everybody's phone?
I mean, everybody's phones are off, so.
What can I say?
Just in case. Okay. So I think to me, and again, as I said, I live in a particular world where we work with companies and progress big data strategies and machine learning strategies and new computational techniques. That's what we're really all about. So again, I think I see it through those eyes, but I do think there will be incredible changes as a result of sort of computational techniques, and I see those already starting to happen. Now, every company these days, almost every company that I hear a pitch from, and to give you some idea, I've probably heard about 100 or so new company stories over the past 12 months. And it's routine now that they come with a technology or a device or whatever, and they say, and it's also a big data play. And for the most part, it isn't. They're really not. But they know that people want to hear big data. They know that there's acceptance of big data. And I'm assuming people understand the concept of big data just on a very high level. I see, the way I think about it, I see medicine as a series of probabilities. We give a new drug to the medical profession and we say, this works in 65% of cases, or this treatment works in 50% of cases. The reality is we never say which 65% because we haven't tested enough variables. So the fact we're giving people those probabilities implies to me we just don't have enough data. There is an actual reason why a new drug works for 65% of people and not for 35% of people. We just don't know what it is. It's not mystical, it's not magical. We just don't know what it is yet. And the idea is that if we connect enough information, and with electronic health record systems, genetic tests, the world of the mobile phone giving us information about stress levels and sort of what people eat, where they live, all these other factors that could be influencing things as well. Eventually, we'll get to the bottom of it. So that's a concept which I think will become real over the next decade, and it's already starting to happen. Again, referring to a live call, we have now there about 1 million ECGs as of midsummer this year. We'll have about 1 million ECGs in the system. So, to some extent, that's the early stages of big data. But even based on today's knowledge, there are things we can do for medicine. I think the idea, the best way of thinking about this, think of the concept of a specialist. We create the field of a specialty, a specialist neurosurgeon, a specialist oncologist, a specialist cardiologist, because we're acknowledging that no one person can be a specialist in all of medicine. It's impossible to track all of the new papers, all of the new developments, everything that's happening across the broad range of medical specialties. So we allow people to specialize. Now, that's a human limitation. It's not a computational limitation. And to give you an idea of this, there's one company that we're invested in, a company called Lumiata, who have spent about 20,000 hours of doctors' time compiling all medical information in different specialties in a digital format, in a programmed format. And they can point to about 160 million different arrows, things, particular things that you can see about a patient that might point in one direction or another towards particular different types of illness and disease. Now, that's more information than even the best doctor in the world can hold in their head at any one time. And to give you an idea of how effective it is, they just did a project with one of the big health systems on the East Coast, and they were given about 90,000 or so health records, or 90,000 or so patients' records, just over a 2-year period. So really quite limited. They ran their program through that entire system, and they found not hundreds, I would say more than 1,000 undiagnosed conditions. Things which were not detected. Even though these patients were actually under the care of the health system, they hadn't been detected by the doctors they were treating them. And the chances are they were outside of their particular specialty. There were about 250 cases of type 2 diabetes, 100 undiagnosed atrial fibrillation cases, 200 hypertension cases, none of which have been detected during that 2-year period, but all of which could be detected by the system. So I think that impact of the future of data is big, it's massive, it can make us much more granular and much more effective in the way we deliver medicine. But I think we have to realize that those changes are already here, they're already possible today, just through more effective use of computers.
Thanks, Ewan. John, you innovated and created the CyberKnife. In your experience, your personal experience, can innovation really have global impact, or innovation has to be local, regional, look at the sensitivities, look at the ground realities?
Well, the answer is I don't know again, and I think that practically speaking is most innovation tends to address the local needs of the community. However, there certainly are examples where I think here in India you're developing processes perhaps for healthcare that with a little bit of effort could easily be translated and transferred to America. However, more often than not, in America, we see we're developing a drug for cystic fibrosis that may cost $200,000 a year, which is just, I think, unfathomable to expect that you can transfer that kind of technology and those ideas to India. And by the same token, sometimes Indians are able and willing to sort of perhaps deliver a less effective and sell a less effective HIV drug than would be perhaps acceptable in America. But I think what I'd like to believe is that going forward, we're all going to start thinking more globally in our innovation sense, is that increasingly, as we make a product for one market, we can think about how to spread it around the world. Because I think it's good business, but it's also good as a physician. And I'd like to sort of harken back to what I'm trying to do at Curious, because I'd argue that information access, and both in the author side and the consumer side, and including physicians, is a problem across the world. Now, sometimes here in India you say, well, Americans, they have everything. But in fact, if you're at a big medical school, chances are you have everything. But for the vast majority of physicians who aren't in big medical schools, they don't have access to a lot of the journals. And in fact, patients have almost no access to medical journals. And here in India, sometimes it's the reverse to some extent. You have some access to journals, as you're pointing out here at Apollo, but it's sometimes harder to publish your new discoveries in the medical literature. In fact, if you look at who controls the medical literature is controlled by the city of London, maybe a couple cities in Germany, Amsterdam, Philadelphia, Washington, D.C., and Boston. And you'd think that the whole world of medicine just happened in those areas. But in fact, there's incredible biases against papers submitted from India, Brazil, Russia. And so the view of Curious is that we're a global community. We should all be kind of communicating, and we all in a global context, and that there's actually a cost-effective way to do it. So we both address a cost-effective need in America, as well as, I think, a cost-effective need in the Asian continent. And in the end, I think by thinking globally, we all win. So I do believe that it is possible to innovate in a global context. By the way, I'll sign up for Curious. It's free.
Rajiv, what role do you visualize for the government?
Yeah, so I think it's a great question. We've been working with the Indian government for 7 years now, so we've seen, I think, a precedent of success when it comes to innovation. I think innovation, I keep bringing up innovation, I think innovation is going to be critical to solving some of India's kind of health issues and creating scalable and sustainable impact. So I think from what we've seen is that governments can fund the academic programs. There are probably collaborations between maybe Western universities like Stanford and Indian entities. I think there's an opportunity to fund incubators to take some of the more fledgling companies or ideas further once they leave these academic institutions. I think funding some of these new enterprises is something that the government of India is already doing, are currently doing. I think a very critical thing, which is maybe less understood or less appreciated, is development of the ecosystem. So as you think about medical technology, for example, there's little pockets of innovation across India, and until recently, people weren't communicating. When you're not communicating, you can't really share best practices and help each other. So I think in time, as the system develops in medtech and other kind of areas, I think there's more ability to share kind of best practices. And finally, I think the other big thing is collaborations between academia and industry. Compared to Stanford, where the two academics and companies are very much tied together, and mostly in a positive way. In India, I think that's yet to happen, right? I mentioned the same disconnect between engineers and physicians, partly because of the educational training. So the more that we can promote some of these collaborations, which are atypical, I think then you can promote kind of innovative cross-disciplinary solutions, which may be a product, could be a service, could be a business model innovation.
Does government foster or inhibit innovation?
It's a good question. I think it has the potential to foster great success in innovation. So,
is there an example of it really fostering innovation?
I think our program is doing just that. At the
From
same
government,
time,
government.
Yeah, it's a government-funded enterprise working with government-funded academic institutions. Now, at the same time, you think about regulatory issues that are created by governments, and that can inhibit progress. But I see great potential, especially for what we've seen from the Indian government. I think there's much more to come.
You're too politically correct. I think there's no reason it can't foster innovation, but I find that more often than not, government is a most kind of disincentive of all for innovation. But Anyone from government?
Okay, how many of us here are doctors? For all those who are doctors, please raise their hands. Okay, so about 40% of us are doctors here. Now, Vinod Khosla was over to Hyderabad for our patient safety and transforming healthcare conference that we run once a year in September, and he was there in Hyderabad, and he made a fantastic presentation. And he said that 60% of what doctors do can be done by machines by 2020. So by that logic, 60% of what 40% of us do, or if you look at another way, maybe a third of us will not have anything to do by 2020.
I don't believe that.
So let's get Ewan to comment on the 60%.
Yeah, so I was delighted to see this question on the list. Thank you very much. And I actually have to make it even worse for myself by saying that what Vinod actually says is 80% of doctors. So I can't let myself off the hook there. So calm down, John. It's all right, calm down. So the reality is, you know, a lot of what he says in this respect is designed to prompt some reaction and to get people to think a little bit differently about the way medicine is delivered. And I think it's clear in the context of India and the context of the conversations today that you know, even if it's true and 60 to 80% of what doctors do today were to be changed and done in a different way, then there would still be more than enough for doctors here to attend to. So, you know, it may come across differently in the States than it comes across here. Here it would mean, you know, 3 to 5 times more capacity for physicians rather than you know, less physicians. So I tried to think about how to break this down, and you know, I'm a physicist. I've worked in healthcare all my life, all my working life, and I've never met a doctor who didn't complain about the amount of administration they had to do. So, for example, you know, I'm going to estimate, you may have different opinions on this, but you know, 20-25% on occasion of what doctors do is actually administrative, and we must be able to do things about that. We must be able to help that. And paradoxically, I think the more senior physicians become, the more administration they take on and the less time they actually spend on the hardcore medical efforts of treating patients and diagnosing patients. You know, the next step was a little bit harder for me to quantify until I heard Lord Crisp's NHS story this morning, and he said that, you know, patients looking after themselves in the home environment were 25% 25% less resources. Many of those resources were doctors. They were doctors that would have seen them in their clinics, as opposed to you know, just sort of monitoring them from home. And then, in addition to that, the other aspects of this are, you know, sort of downskilling certain services, downskilling what's done. Technologies have the ability to do that. I mentioned just now, you know, Lumiata system assisting with diagnoses. Maybe that could be embedded inside an electronic health record system, so that, you know, whole steps in the medical procedure could be avoided or limited. You have intelligent devices that can be deployed into sort of GPs' offices to save specialists seeing every single patient themselves. So that's the basic principle. So I wouldn't get hung up on the actual number. I think the idea of throwing statements like that out there is to get people thinking differently about healthcare and the way at which it can be delivered, and really focusing down doctors' time onto the most effective and impactive you know, sort of use of that time that you can achieve.
John.
Well, I'd just like, if we're going to be provocative, follow up, you know, what would you find over the last 5 to 10 years in America that the system of healthcare we're adopting requires even more physician time, even more physician input, and if anything, it answers the question I posed earlier. Is government foster innovation? And heck no, it does everything it can to inhibit innovation and better processes going forward, at least the American government. So this is a segue into my next question.
So John, do you believe, you know, we heard that the Indians are great at innovation conceptually, and they're wonderful when it comes to developing stuff when they're in the United States or elsewhere. Do you really believe that India can become an innovation hub? What will it take for us to change our mindset?
Well, first you got to believe you can do it, and there's a certain measure of confidence that goes with being an entrepreneur, because you are going to face You're going to face risk and failure. And the first thing an entrepreneur needs to accept in life is that you are looking at failure and risk every single day. And so you got to have a certain measure of confidence. And I don't think India has that yet. My dream is that they will get it in time as the Indians who migrated, his ancestors migrated to America, they become great entrepreneurs, and they come back and spread. The Indians can now look one another in the face and say, if that dumb Indian can do it, I can do it. And so the point is that innovation it's human. And the Indians have been incredible innovators, entrepreneurs, risk takers throughout the entire world. There's no reason to believe India can't do it. And yet the advantage I think India has is that it hasn't built up this regulatory thicket that you see in much of the developed world, which I think is a big inhibits progress and innovation more than anything else. So I see the rawness of the Indian healthcare system as a great advantage and feel that there's an opportunity before a blanket of regulation sits on top of it to sort of see if you can't figure out new ways to make healthcare, improve healthcare. So this is why I believe in India, and this is why I'm here to be happy to participate in this conference.
Rajiv, what obstacles do you think we're going to face
Yeah,
in the next decade?
Yeah, so I'll actually add on to what John just added, which is the sphere of is risk aversion is something which I think is problematic if you're trying to create something new, innovative, entrepreneurial. There's a fear of failure, which may reflect upon the individual, may reflect upon the family, for example. So I think that in time will change. But as far as the obstacles going forward, I think people need to recognize that the needs of India are very, very heterogeneous, meaning north, south, east, west. They may have different needs and how something could be treated. Secondly, even within a city, even within a few kilometers, whether you're in a government hospital or a corporate hospital or trust hospital, now the nature of the treatment may be fundamentally different. So that heterogeneity actually it can be quite difficult when you're trying to create a product which is relevant for the masses. The other thing has to do with, and this is something that we've learned in our program, is that it's not just about creating a product, an innovative product, it's also creating a business model which supports that product, and that has to be understanding the stakeholders in India to create something which is a viable, sustainable, scalable business has to go in concert with product development. So I think all of those are important obstacles going forward for India.
Ewan, you said something very, very fascinating, and perhaps we'll get John to respond to that. We all know, and there's enough data to say that it takes about 10,000 hours to actually become really good at what you do. Great musician, a great cricket player, a soccer player, a chess player, what have you, it takes that much time. And it's so interesting that when you cross the 10,000 hours and you really get good in medicine, you spend more time doing admin. Isn't that really, really odd, John? I mean, what's the logic for this? What's the historical basis for this? Why do we doctors do this to ourselves? When you're really good at something, you end up spending half your time doing admin.
Well, in America, if you don't do the admin, you don't get paid. So, I mean, it's survival.
It's the government, John. It's the government.
Yeah, the system. Thank you for saying it. Thank you for saying it. I mean, if you want to go into your clinic and you want to get paid, you got to fill out the paperwork. And then the rules aren't created by fellow physicians, your colleagues. So, I'm sure it's no different in the NHS. I'm sure it's no different, probably even in India to some extent.
Right. We're going to throw this open for a lively Q&A. So just identify yourself, and if it's a question that you want any of the three to answer, then so be it. But if you have a specific panelist in mind, please. Could we have the ladies with the mics around? So we need a mic there, we need a mic here. Yeah. Could you just give, yeah, okay, great, please go ahead.
I'm Dr. Balasubramanian from Chennai. The symbol of any doctor is the stethoscope. I read an article that stethoscope will not find a place in another 10 years. Is it a fact?
There will be no role for a stethoscope soon.
I mean, there are digital stethoscopes. There are, digital ECGs. We have sort of biometric sensors that will, sit in your wrist and measure everything pretty much. So I don't want to specifically pick on the stethoscope and say that would be gone, but I think there'll be a new range of ways of measuring things which may circumvent traditional ways. We have a digital otoscope, for example, for sort of taking pictures inside the ear. And the advantage of doing things in a digital way like that is that, A, you can analyze the data, you can also share the data. So, a patient at home with a child with earache can actually share, without a consultation again, can share that image with a pediatrician or ultimately maybe with an ENT professional. So I think the impact of digital technologies is probably going to be big, but I don't know that I'd pick on the stethoscope as a particular scapegoat.
But as all of us will agree, the utility of a stethoscope has decreased over the years, hasn't it? I mean, the chances of making a mistake when auscultating for a cardiac murmur vis-a-vis an echo, I mean, nobody will argue that, you just cannot compete with a good echo. So clearly, I think the utility for some of this will decrease over a period of time, but I don't think it'll go totally out of fashion or
I
out
think
of practice.
low-cost ultrasound devices are going to actually replace the stethoscope.
Thank you.
Thank you. I am seeing this future of the healthcare is in a different way. The first is teaching and training. Number 2 is practice of medicine. Number 3, other factors. Regarding the teaching and training, I think it is going down because the best students are not at all going to the medical colleges. And about 6 months back, I read in a paper that for an MD radiology, there was an open auction and it has been fixed for 4 crores. Then what will be the future of the medical education? Number 1. Number 2, we are telling that there are scarcity of the doctors in the rural area. The maximum scarcity of doctors is in the medical colleges. And another thing I have to say is that we are telling that accessible and affordable healthcare regarding the ordinary people. The middle and the smaller hospitals are getting closed now. Then how can they get the accessible and affordable healthcare? And another thing is that regarding the training also, what is the standard of the paramedical people? It is not according to the requirement of the doctors they are trained. It is according to their whims and fancies. For example, I can assure you, a BSc nurse can pass the BSc without touching a patient.
No, I think you make very valuable comments. I mean, there is a serious problem in that medicine no longer is as popular as it was a decade ago. I mean, we've seen that, and that's because it takes forever to train as a doctor, and perhaps we need to really relook at the curriculum and actually, how many young people are willing to spend 12 or 13 years training to become a cardiologist, and that's clearly an issue. And perhaps the medical council and the professional bodies will of course look at that, and that is a serious challenge. But of course, what we're trying to do here is to figure out that what a doctor does can someone else less qualified do, so that even though we're not going to be able to make up the shortfall of the number of doctors, we'll perhaps be able to reach out the targets and being able to reach out to people. And of course, what you say about funding and all will actually take us in a different direction. So I don't think we can debate too much about that, but thank you for your comments.
I am telling this for not debate.
Yes.
And another thing is regarding practice. I think no doctor can practice medicine with his conscience and the ethics. I will give you an example. Suppose...
We're going to run out of time, sir, and we have another person, so perhaps we could discuss this offline. Yeah.
Excuse me.
Please go ahead, and that'll be the last question.
Samir Mehta, Dr. Mehta Hospitals in the Atlas Family Office. Actually, comment and perhaps 2 questions. So the first one is, we're seeing people concentrate a lot on electronic medical records and the technology of an outcome rather than the process of getting to an electronic medical record. And the challenge we see in our health systems is a doctor will spend less time communicating with the patient and interacting. And so it's a question for you, why are people focused on the wrong part of the process, not the method, but the outcome? Is it because it doesn't pay? And maybe I'd love to hear some thoughts on that. And the second piece is a question around, as we go down personalized medicine and genetics, the cost of the therapy to treat the outcome is going to be much higher per procedure than it currently is. The system might get lower because you're isolating all the preventative stuff. So from an engineer's perspective, it just sounds a little bit strange, and I'd love to hear the view. And I guess a small comment to that, if you can concentrate on the nursing and the allied health community a little bit for training, because with 40% empty seats in our nursing colleges, we're going to need nurses to keep the doctors allowing to sleep at night.
Any of the three of you?
I don't know where to start with all of that, but there are a lot of very good points there, I think. For sure, it's one thing saying you can de-skill if there's somebody to de-skill to, that's clearly a very, very important issue. I wasn't quite sure the point you were making about the electronic record system, but I think the way I see this is that people are asked to keep records, sort of electronic records these days, simply because, at least in the US, it's a very much of a medical, legal type of issue. But it's also, of course, follow-on and diagnoses and tracking patients' progress through the system is really important. The way I would like to see that evolve, though, is really the way that I'd mentioned earlier on, which is that I'm starting to believe that those systems themselves can have an intelligence built into them. So that something being done in one part of the hospital, maybe a patient goes into the ER for some particular reason, capturing information and actually accumulating information across the board. There may be ways in which the electronic record system itself.
All I can say is someone who's worked with electronic medical records, there's no intelligence in them whatsoever. And poor Amir Rubin has to listen to this because he writes checks for hundreds of millions of dollars, but they are constructed by idiots for idiots, and they just suck the life out of medicine. So what can India do? India could make, finally, a good electronic medical record, and you could save America from itself.
So there's the opportunity. There's the opportunity, exactly.
Right.
Exactly.
Be innovative.
Right. Well,
A valid question. How did you invent the cyber knife? What made you do this invention?
Naivete. I had no idea what the hell I was getting myself into. And if I did, I probably would have never done it. Because what you find when you invent something, you create something, you fall in love with it, and you just can't give it up, and you obsess over it, and before you know it, it becomes your life. And that is the nature of innovation. And it's a fun thing, but it's a scary thing, because when and if you fail, it's painful.
That's not what you told me, John. You told me it was the government.
No, I said it was you.
Well,
the next best thing to government is you and Thompson.
Well, it's been a really fascinating session. We talked about you, so we believe that each one of us will become very important in the next decade or so. We talked about big data, we talked about computers, we talked about medicine changing from the problems that we have of too much probability to perhaps having algorithms that we can use. We talked about innovation that's going to be cheap, like the splints. We talked about, well, while innovation has to be global, technology can actually make it regional and sort of site-specific. And we, of course, talked about the problem that we as Indians have is about being worried about failure. So that
Lastly, you talked about Curious being the future of all medical publishing.
So thank you very much, and you've been a fantastic audience. And over to you, Rini. Thank you.